BCNC is that we know that people face problems beyond what they come for. I mean, people might come for English classes, they might come for childcare, but that's not the only challenge that they're facing. But in order for those challenges to be addressed, they have to have a trusting relationship. And I think that's the importance, not just of organizations like BCNC, but in all these kind of marginalized and underrepresented communities, of having organizations that are in those communities, that are led by people from those communities, staffed by people from those communities, whose decisions are made based on what they know from the population in that community. So we have, like Cindy was saying about the sending children overseas to be cared for. We had Cindy come speak years ago about this research and the importance of the potential risks of sending children to be cared for by family overseas. And I think we had a few expectant mothers who were in there who just left and said, I don't feel I have a choice, and knowing this information doesn't make it any easier for me. And so we had to re-examine how we try to encourage families to stay together. So over the years, we have continued to adjust our approach. And this year, what we're doing, we developed this with input from Cindy. We're working with Southfield Community Health Center and also with BI in helping to make, to do like a pathway for people who are expectant mothers, then when their babies are born, and then coming to BCNC for services, light touch, things like infant massage, which is just, it's therapeutic for the baby, but it's also primarily what we're interested in is bonding between parents with each other, parents with their children, and also creating a support group for new mothers in particular. So if they do have postpartum depression, or they do feel that they need, they can't afford childcare, they're going to send their child overseas, that it makes them think about the community that is around them that can help support them through these difficult challenges. And so rather than kind of come from a perspective that is not meant to be punitive, but can be interpreted that way, about telling them all the dangers, I think that by accentuating kind of a positive and saying that you're coming to us not for help, but you're coming to us to kind of build a community, it's all just a different lens to try to make families healthy and keep them together. So this is kind of, I think, it's not just us, but organizations like us who provide services in a community and have years of experience doing it. I think that kind of expertise is really valuable.
So I have more questions, but at this point in time, I'm going to open it up to the audience and see if there's anybody else that wants to continue with all of the questions.
I have a question, which is how to manage the kind of research that we all need to do in very difficult times. So I don't work particularly with Asian communities, but the communities in Somerville are leaving because they're being gentrified, which is a problem also here in Boston. And at the same time, people are terrified. They don't want to open the door. We're doing a study right now with the EMC and Health Game Shelter Lines looking at patient no-shows, which anecdotally are all immigrants. People are coming in to get birth and not getting care. This is all a function of the last 2 or 3 years, which makes research and data collection incredibly difficult, simply because also we have populations that are, so the Haitians have left Somerville for Everett and Randolph. They still have ties to the community, they still come back to church, but they're dispersed in ways that make it very hard to study. So I'm just sort of wondering how, your reaction, things that you might be doing to sort of capture dynamism.
There's no answer for sure.
Yeah.
I think there's a lot of different answers, right? And you made me think around the gentrification piece. That's impacting a lot of our communities, a lot of neighborhoods, and there's a lot of efforts that are happening. But that's also a great example of how communities have come together around an issue across communities. And so, how do we create opportunities for folks to come together across communities is through events like this where we can start to talk and start to hear about it. I remember when I first came to BU for Tufts there, I was partnering with the Community Development Center at the day, and they were really interested in gentrification. And so, but there were other groups, I had other collaborators from Tufts who was working in Common Square and encourage Prosper on gentrification. And so, because we all were talking, we were able to bring together a forum with different researchers and community stakeholders from different neighborhoods to talk about gentrification. And it was great because then city leaders could be doing it. But I think part of it is talking about the issues and how, we're always cut, that's like one of the great tools of white supremacy culture, right? Cut communities into identity groups and divide. But the reality is that communities of color and immigrant communities, no matter where you're immigrating from, we're facing a lot of the same issues. And so the more that we can have opportunities to communicate, come together, bring our researchers with us, and get our researchers talking, then we can think about partnering in our collective voice will be much larger. So there we go.
I don't have any answers, Alex, but I just want to reiterate, like I agree with you, that this is a huge concern. And, one out of every 7 undocumented people in Massachusetts is Asian. And our Mayor Walsh, and Somerville's saying the mayors have been pretty vocal about saying that this is a place where undocumented people should not fear, being a full member of their community. But the fact is, people are scared, and fear is being sown intentionally in our communities to prevent people from participating. And by not participating, of course, that leads to all these other things, like you're saying, mothers who are not getting prenatal care, people who are living in unsafe or substandard housing, overcrowded housing, because they want to stay off the radar, people who are working under the table jobs, so they're being exploited, their labor is being exploited, or what have you. People not reporting crimes, so because they're scared of what could happen to them. So the impact of this is widespread, and I think it's intentional. And the one tool that we're supposed to have, the tool, the census, is supposed to help us count every person, but our organization and most organizations are involved in telling their constituents to please fill out the census, and but if people are scared to fill it out, I can't blame them. When DACA and DAPA became available, we did tell people that this was a great opportunity for them to work, and but people were scared that it was going to be used against them, and it has been, and it wasn't supposed to be. That's supposed to be illegal, but that's what's happening. So it's hard to be a service-based organization trying to encourage people to take advantage of the rights that are afforded them, while also knowing that they have fear, and those fears are actually not unfounded. It's an awful environment that we're currently in for immigrants and other marginalized people, and I think that typically what people will say for inspiration is you just go and vote and get those folks out of office, but this is such a widespread issue that I honestly, I fear it will take generations to repair the damage that's been done in the last 2 years. So that's not an answer. I just felt I wanted to say it.
Can you each give example of how the your own unconscious bias influence how you frame the question, the research question, or if anybody? So for example, I remember recently at that meeting, one of the researchers shared that they were asking this question to the community members, say that in the last 12 months or something, have you ever ask for assistance, for in the pharmaceutical company for help for interpret the prescription or usage of the medication. And then all the answers came back says no, and they were really puzzled because these are people who really don't have the English proficiency. But then later on they found out that it's because when they these people, they actually go to the pharmacy, they have the pharmacists who already have the language competency. So if you just ask the questions saying that this is we wanted to know if you have need for interpretation translation. And then they did, without realize that these people go to the pharmacist, in the first place, that they know the language. So just wondering if you have any other example that you can illustrate.
So I could say something about, when you're talking about a data collection effort like the one that we did, that's based on the BRFSS, you're making certain assumptions that those are the factors or those are the determinants that we should be monitoring, that we should be collecting. And so what gets onto that is part of a political, a deliberative, a communal process. And so there may be groups that haven't participated in ways, I think Dan can also speak to that. But I will give another example of work that I did much earlier on in my training. I was a research assistant on a project where we were working on the Cancer Risk Index. And the Cancer Risk Index was taking all the epidemiologic data that we had up until that point, and you could then type in different things and it would tell you how your risk compared to the rest of the population. And this was before the computers, the computer thingies, I'm pretty old, were so common. So it was paper and pencil. And we were doing focus groups around Boston, and we happened to wind up with a focus group of all African American women in Cambridge who came and did the survey. And so this included, of course, all the data that we collected to look at of what are the cancer risks. And they went through and did the thing, and then they said, well, where's stress? Why isn't stress on here? Everybody knows stress is unhealthy. This should have stress on it. And so, that maybe there's a link, maybe there isn't a link, but probably at that point, because that was, the data leading up until then, which was 18 years ago, there hadn't been sort of a looking at the relationship between stress and cancer, and that was a risk factor much more experienced in they felt in their population than in other populations. So I think one of the biases or assumptions is that we have the data that we need. We're asking, well, I guess that's the whole point of this. But I think it's incumbent on all of us to engage in these conversations to make sure that the kinds of factors that you think are missing are getting joined into that dialogue and are starting to find their ways into some of these massive data collection efforts. And I think, here's how to do it.
No. So trying to find the right questions requires, I think, really engaging in conversation and reaching out from our standpoint. And so we've got the survey that we do, and every couple of years, and we try to use a lot of what the CDC is using for comparison purposes there. But we've had the ability to bring in our own questions that we feel are most relevant to the Boston population on the whole. We identified questions from our outreach into communities, and an example of that, currently we're supporting the Boston Community Health Needs Assessment process. It's collaborative, and I'm on the secondary data committee there, and where we've had a lot of community input with respect to the type of data that is of interest. And so at different points in the process, it was community folks asking, do we have any measures on this? Do we have any measures on that? And it's those kinds of considerations and dialogues and discussions that inform, to some extent, the content of what we end up putting into our survey. So, for example, we're now asking around housing security and around food security, food access, and even social supports. These are sort of new questions. It's a limited size of the number of questions we can ask, so we have to prioritize. When we bring some on, we lose others. But it is, I think, addressing that. So addressing biases comes back a lot to communication, generating. There's many types of bias, but generating results and communicating that, and learning about what's not there, and then and what is of interest, and that informs us.
I think one of the things that was interesting when I was at the, we conducted this like 12-month series where we visited the senior housing in Quincy, and because they would rather have us over rather than having to come out, so we decided every 3 months we would visit the senior housing, and then we get together in the social room setting, and then we did a workshop or measure their A1C, which is like your blood sugar report card for the past 3 months. So that's why every 3 months we visited and see how they're doing. And one of the workshops we did was together working with the pharmacy students and professor to do the brown bag session, where we asked the residents to bring all their medications, because by then they have like multiple blood pressure, diabetes, all that kind of stuff. And then we wanted to really open up the conversation if they have any questions, how to take it, when to take it, if they have any kind of effects one another. And then we realized, or I realized, that for them, many of them had herbal tea or some kind of supplement that a lot of, for example, their family member from Hong Kong or Japan or China, they send it over because they know that it's good for your blood sugar management. So they will combine those together with the prescribed medications that they were prescribed by the doctors here. We didn't realize that how much of those they usually don't report it to their providers, because they think it's just the herbal tea, they think it's the supplement, vitamins, so why do I have to tell them? And then we realized that there's a huge gap. So it was really the wording, how you were all saying about the communication. Like, we want to know what else you're taking, including such things, because at the end of it, it helps us figure out what is better for you and what's the good timing. Because if you don't tell us, we wouldn't know. And that also goes back to compliance as well. Like, because of the back to the authority figure doctor versus me, just the patient, sometimes when they forget taking their oral medications, they wouldn't necessarily say that, hey doctor, I went on a vacation with family, I totally forgot my meds, and I wasn't on it for the past 5 days. But instead of letting them know, there will be just, yes, I took the medications. Yes, but then somehow the results is not, showing what they're saying. So for us, it's about asking the question based on the assumption. Unfortunately, it may be biased, but that there may be some potential that they weren't able to share with us unless we ask them the right questions. So it's really the back and forth, how we tend to notice something thanks to the engagement that we have, or we mobilize a lot of student volunteers in our workshop or outreach activities. So we also ask them to have a lot of open dialogue. And then at the end of the workshop, we ask the student volunteers to give us the feedback, not just from the participants, but what they've noticed. So we have all sorts of fresh sets of eyes, kind of looking out for the opportunity, like how we can better tailor our questions and survey. And lastly, what we found very effective was that a lot of, like going back to Giles saying that, why do I have to do the census? I'm scared to provide my data. For that, as simple as like a little evaluation form for the participants survey that we do, we try to do our best in explaining why we're doing this data collection. What are we going to do with the results that you provide? Like, what's our hope and what's the goal? And how would you have an access to that result? If they're interested, or just as an outcome. So that really helped, because people are afraid, why am I even writing my name or the phone number. Because we want to follow up. If we do the diabetes screening, we want to make sure that you talk to your providers. So all these little things that we maybe sometimes forget, it's really important for the participants because that's what we hear. So I guess depending on the style of the data collection, as little as like group of 10 people or the focus group, we really have to take time and effort to explain why we're doing this and why we need their help in providing us some information. I think that makes that
So I do a lot of youth led participatory action research. It's essentially thinking about community participatory research with working with young people. And I've come to realize over like the last few years, I have a lot of bias as an adult, right, in terms of perspective, the way I see the world. But luckily, adolescents are really great at holding accountable to bias. And so a lot of times when we're bringing together teams of young people and they're coming up with research questions, I always have a set of assumptions about what are the research questions. If we're looking at barriers to health and well-being, what are things that young people identify as barriers to health and well-being? And I always have a set of assumptions in my head about what kinds of things will come up. And I'm always wrong. And it's amazing to me. It's funny because, in school you learn all this training about how there's all this stigma around mental health. This is the most recent one that I've experienced around mental health. And people of color don't talk about mental health. And men don't talk about mental health. And youth don't talk about mental health. And in the last 2 groups I've worked with, one here in Boston, predominantly foreign-born, generation 1.5 youth of color, and they were predominantly young men in the group. There were only 2 women, and their main concern that they wanted to address was mental health. The same thing just happened to me in Staten Island. I was working with high school training young people in mental health. And so I have to but say people don't talk about mental health, but they come up this generation, they talk about mental health and its importance. And then they go on to talk about how, adults never talk to us about mental health, because they have all these stigmas around mental health, and so it's kind of like, it's way too why are they leading with mental health? But I think it just demonstrates the importance of meeting people where they're at, talking to them, and hearing what their concerns are before you formulate a research question, and before you identify priorities.
I'm just going to toss in there that in my work, one of the things that I constantly ask myself is how can we create the space to let other people surprise us? And so, I don't always do it, but it's a constant question that I'm asking myself.
And I found myself, especially hearing the discussion about talking about natural herbal cures, etc., remembering back probably close to 20 years ago. Dan, when did the REACH 2010 Boston Elders first start? This was Boston Public Health Commission in Action for Boston Community Development, where I work. We did the focus groups to get some of the initial qualitative data for BPHCs out of REACH Boston Elders. And I was taking the notes. I was hand taking notes and taping them. We had a group of African American seniors, I think they were all women, and the person leading the focus group was herself African American older woman, nurse, and she asked them a question in this setting, this formal focus group setting, of something to the effect of, do you use any herbs or natural remedies for diabetes, et cetera, and the women in the focus group were like, no, I don't think so. No, I don't use herbs, etc. It wasn't just for diabetes, but it was a broad question. And as the focus group ended, and the group wasn't quite comfortable talking with each other, they just all started chatting. I'm still sitting to the side taking notes, and they all started swapping herbal remedies and medicines and teas and soups that they do for their spouses, for themselves, including the woman who was leading the focus group. They're all swapping these medicines when they all just before said no, they don't do it. So how do you design settings, or do you need multiple settings multiple times in order to actually start uncovering people's actual practices?
Hello? So at Jocelyn, we have Jocelyn Clinic, and we also have Jocelyn's Asian Clinic. And Asian Clinic is the part-time clinic where we have Wednesday afternoon and Thursday morning open to those patients who prefer to be seen at the Asian Clinic within Jocelyn Clinic. So one of the things we do is that if you are of Asian descent who would like to be working with the providers and educators who may have more experiences and knowledge about the diverse Asian culture and the diet, that's where you go. But one of our unique systems is that we have a coordinator that's solely focused on the Asian clinic. So our patient, instead of, if you call the general Jocelyn Clinic, we have a group of really passionate coordinators who will route you through the doctor's office and all that. But our clinic is so small. We have one person, her name is Julia. Julia is the one that you always talk to. So in the end, our patients develop a relationship with Julia. And also our providers and educators have a weekly case study session. So when you become a patient at Jocelyn Asian Clinic, whether you like it or not, you're part of our family. And then over the years, we really developed the communication channel, how you can mention stuff or remind us, not just to your providers or educators, but also to someone like Julia. So I think it's important for us because when we do conduct a study, one of the first people that we reach out to is our clinic patients and then beyond. So it takes a longer practice, and to answer your question, I think in our case, we really need to have a long-term relationship with the patients, and also a lot of times their spouse or family member, caregivers, they will call in as well. So we know who they are and then what kind of story they have. Sometimes they may have to travel overseas and then they have to have letters by the doctors for their insulin. All those things, or they get laid off, they may go through divorce. All these life changes, we're able to be there with them. So I think at least for our patients and their supporters, we find it easier when we have a long trusting relationship. And when we do go out in an outreach setting, we still get, as soon as we whip up this Jocelyn Diabetes Center, Asian American Diabetes Initiative, like a table runner, everybody starts going, either go back, I don't have diabetes, and then they go out. So sometimes we just intentionally don't use those table covers. And then we say, hey, do you want to measure blood pressure? Do you want to talk about Asian tasty food that's healthy? Or we even conduct cooking demonstration where our dietitian whip up the brown rice, fried rice, and then have them come and sample. So I think for the short term, the random encounter that we hope to start a relationship, it's more about how do you attract the particular audience. But when it comes to really one-on-one conversation, we tend to go for the long-term relationship.
About 7 years ago, I had a software programmer who was doing a lot of programming work around the survey that we were talking about earlier, and she's Chinese American. She came over from China and working in the office. And one day she came in and told me that she got the call for the survey. And I said, oh, great, how was your experience? And she said, oh, I didn't do it. And I'm like, are you kidding me? This is our tribe. We were trying to get Asian respondents, we're oversampling Asians, in trying to get enough. And she said, oh, well, culturally, we don't share that information over the phone. And I thought to myself, oh my gosh, we're in trouble here, right? And so then subsequent conversations, and we have been oversampling Asian, we continue to do that, but I think that then you have to rethink about what you're getting and what you're not getting, and that leads to, well, maybe over the phone isn't the way to do it. Maybe it's knocking on doors and having a face-to-face discussion. And that's just for participation. You still don't know that your tool is good, that the questions you're asking, that they're going to be forthcoming with the information. So we've had, we've put questions out there for various reasons where we get a much lower response rate than we'd think. A good example might be, have you used opioids in a non-medical manner, so essentially illegal behavior, in the past year or something, and the percentage, of response is much lower than we would think is the case. And so I think one of the lessons there is, if you have good cause to think that asking this question isn't going to get you the right information, if folks aren't going to be sharing that with you, if there's stigma attached to it, it's probably not the vehicle for getting that information. And you actually it might be more of a disservice of trying to quantify that and push that out. And so you've got to be very mindful of that as you look at the data and really try to understand what's going on there. More recently, we've got an example where we ask sexual orientation questions, and we have that translated, and we've learned that there's been some research around, even though we do the survey in Spanish, that the translation in Spanish still doesn't work well. And so we likely have a lower rate responding LGB because of the fact that it just doesn't translate well. And so you have to be aware of that and then try to figure out, okay, well, is there a better way to translate? If not, do we continue to report out? Do we report out with the caveat that this is the best we've got? And then you look for other ways to try to get that information.
I wanted to say something about something that we have learned recently. Something that we have learned recently, which is that the term Asian can be very problematic. And this is something that we use widely when we recruit, when we try to engage, but it's become really problematic. It's such that people just don't self-identify as being Asian. And when it's juxtaposed with a particular issue that you're trying to set, such as mental health, we find that many go, oh, we're not the Asians that you're looking for. Or they'll say, why are you trying to understand this in Asians when it's a universal problem? And so through our focus groups, we did some focus groups with parents and youth, the community example looking at attitudes towards mental health. The South Asians were saying, again, we're not the Asians that you're looking for. And we don't think it's really mental health that you're trying to understand. We think it's behavioral health. It's like, oh, that's really an interesting distinction that you're trying to make. And they said, this is a universal issue, so we just simply do not know why you have selected a bunch of South Asians for this focus group. So we really have to defend. And then I thought, well, why do we have to defend this? You were sharing something that's really important. But what it highlighted for us is that our strategies for engaging with Asian Americans are not working. So when we do flyers and we try to say, hey, we have a conference or we have a symposium for Asian Americans, and we wonder why South Asians aren't there, that may be a reason why. For the Korean immigrant families, they also had something to say, which was, we're not like Chinese. And I think those are the Asians that you're looking for. We have our own unique, special concerns and interests, and it's really different for the Chinese. So, and for the Chinese, there were just a variety of different responses to our engagement, whether it's mental health, whether it's about student stress. When we speak to youth, it depends on which community. So when we talk to Lexington youth, they might say, yes, mental health is a problem, and we use the word well-being, thinking that it's going to cover everything and it's a lot more palatable. The Brooklyn people say, just call it what it is, mental health. And so the language that is used, the understanding, how it's translated, we're not on the same page. And I feel like we scratch the surface in terms of, recognizing that. And then not just recognizing that, but really utilizing that to engage more deeply and understand what it is that we're trying to get at and how we can actually help a lot of researchers.
same thing, but it needs to be geared to them.
That's exactly what I'm saying. And I think it's generational. So I'm a second generation person, and I identify as all these different things, Asian Americans. So when I see something that's Asian American, I'm like, oh, that's for me. But my parents are not going to self-identify as that. They're not going to go to the Asian American forum at all. But they might go to a forum that's for everyone, if it's about an issue that they care about. And they might go to a forum where it's Chinese Americans or Chinese Americans. Because they're like, okay, we identify, we speak Mandarin, or it's Chinese. But Asian American or Asian itself, they're just like, yeah, that's not it.
One thing is something, you're saying, I have no idea, but, I'm really curious about it, because I think there's something more even underneath that has something to do with this culture, Western culture, and trust issue. I wonder if it's our Armenian issue, I don't know, but it just seems to me something deeper.
Can I jump in on this? And this is not necessarily a public health point that I'm making, but I think someone alluded to this earlier. There is like a political divide in the Chinese immigrant or Chinese communities in Greater Boston. I won't go into it that much, but I can say that the Chinatown or the urban organizations like us that have been around since the 60s have a different perspective on some social issues than folks who, I guess, like to paint with a broad brush, live in the suburbs and came either to go to school or with degrees already. There's like a divide that is pretty sharp between the way that we look at a lot of social and political issues. And I've got, not to get too whatever about it, but I feel pretty condescended to very often when I'm in those spaces trying to build common understanding. I feel that I've had the comment, you must be one of those Chinatown Chinese, which is not a compliment in their eyes. So there is some divides even in, not just between the ethnic groups in the Asian community, but even within what many would think of as the same group, there's a lot of difference. So, and those divides I think are growing, not shrinking. So it will pose a lot of interesting challenges over the next many years.
I was going to add to that. I think just in general, the Asian American is a very broad spectrum, and the Asian American experience varies because we heard there's first generation on 5, 2, 3, all the way to 5, and more generations. And we're collecting data, and we're just kind of saying that as Asian American, kind of what kind of data are we getting, what kind of participants will we get from it, and maybe where it's not, we don't really spot it out, but once we get the data, how can we extrapolate that? How can we use the data that we have to make it more helpful for all Asian Americans or all Asian people in America, whichever group that they identify themselves in, so that the studies that we have, the results that we have on that, it won't be classified by some groups saying that that won't help us. So I think it's still a very new idea. People seeing this cute Asian American spectrum and see where they place itself, and how being a part of this daily community, how they fit in.
So this is our time, but I want to thank all of our panelists for being up here and for sharing all that you shared and for answering all of our questions. And I also want to thank all of you all for participating, for asking really good questions, and for being with us and allowing us to share our stories. Hopefully our panelists will stick around for at least some time after this, so feel free to have more conversations.
Ohio's advocacy. Just take a look at that.
Thank you.
So what we're gonna do now is we're gonna have a quick group photo to memorize the situation. So if everybody can move all the way to the end in the hallway, you will see, for those who were here before, you know that there's a big banner, so you can just kind of line yourself up in front of the, and then for the panelists, can you bring your certificates?
日本語知っ
So
て
we
ます
can have
はい
a
大丈夫です
photo.
よ喋れるんですか
日本に住んでる
どちらに
東京のあなたも東京
私も東京で大学に行って
ここはどのぐらい
ここは10年目です
10年
はい
東京のどこですか
東京は国際キリスト教大学で三鷹にあるんですけど、
はい
そこに行っててその後吉祥寺とか新宿とかに住んで働いてからこっちに来たんで
私が練馬に住んで
なんで日本にいらっしゃったの
モンブションで奨学金もらってきたんですよ
なのに今また今度寒いボストンまで
いや私がモンブションで奨学金できて長崎大学で博士して、それで10年から現在で働いてたんですよ
でなぜこちらにいらっしゃったんですか
だけどイノバラというカンパニーがあるでしょ見たイノバラだから今日のケーススタディは我々が知ったんですよ
そうなんですか、私ね今日何時まで入れるかわかんないんですけど、プレゼンションに興味があるんで、
No, because do you know Dr. Reddy
Ready?
in Boston, Jocelyn Diabetes?
Okay.
Is he still there?
Oh,
Shetu Reddy. This is my card.
yes, let me just get mine then.
Okay.
Yes, thank you.
We're like, I'm doing the Asian American, the Asian Mental Health Forum and stuff. Yeah. So we're all going to get our picture taken. Come on, guys, we're gonna get your picture taken. Come continue your conversation. Oh, people who are planners in this.
exercise